with GU Oncology now, we have Dr. Gomella. Dr. Gomella did his urologic oncology training at the NCI, and now he's at Jefferson. And so we're here to talk about a topic that when I first started residency was pretty boring and now has become pretty exciting. So non-muscle invasive bladder cancer. Why was it boring? What's going on?
Yeah, I mean, it's certainly an exciting time for a lot of cancers, but non-muscle invasive bladder cancer has really been a desert of available therapies, especially for high-risk recurrent disease. For many years, we've had, up until a few years ago, 1 or 2 FDA-approved therapies. And I think a lot of it was due to advances in precision medicine, also BCG shortages, that we've now had sort of this explosion in treatment options and available options for patients that have aggressive non-muscle invasive bladder cancer.
All right, so BCG is still the first line, right? Patients, if it's available. If it's not available, you have your chemotherapy, options. Failed BCG, what happens next?
Yeah, so failed BCG, especially in the patients with CIS tends to be a very, very aggressive form of non-muscle invasive bladder cancer, and a lot of patients get confused. Even though it's a superficial tumor, it actually has very high rates of recurrence and progression. So BCG failure, we have specific definitions for that, but if a patient fails BCG, we used to have to go right to radical cystectomy. And radical cystectomy is a very morbid operation. Patients do not like the thought of having an organ removed if there are other options. And we used to not have any, and now we have additional chemotherapy options, and we have some exciting drugs coming down the pipeline, some that have already received FDA approval, different viral gene vectors and different delivery techniques out there that have really offered some additional bladder-sparing options for these patients.
Okay, so tell us about these.
Yeah, I mean, this could be a 2-hour talk to discuss all the advances over the last couple of years. But I mean, the FDA approvals you had recently in terms of additional options besides BCG are things like systemic immunotherapy. Pembrolizumab now has an FDA-approved indication for this setting. As you can imagine, though, the uptake of pembrolizumab in clinical practice, I know in my clinical practice, isn't great. And a lot of that is due to the hesitancy of receiving a systemic therapy, that even when you explain to patients this isn't standard chemotherapy, they still think it's the type of therapy that they're going to lose their hair with. So that uptake hasn't been huge, but it's there.
Okay.
We also have an FDA approval now. I think it's been almost 3 years for one of the new viral gene therapies, where essentially it sort of hijacks the cellular machinery within the bladder wall and also has some agents to help uptake that drug into the bladder called nadofaragene. And essentially it allows the cells to start producing interferon. And interferon is a huge sort of driver of immune response. So essentially this is boosting the body's immune system to be able to attack the cancer cells as it normally does on a standard basis.
And what does the data show about nadofaragene?
Well, I mean, the early trials showed great response rates, around 50%. So that's what led to the FDA approval. Sort of in real-term practice, we're getting close, 40 to 50% in sort of real-world use. Certainly some of the challenges with the drug, it's great to have that option, and we've just started using it in our practice about a year ago. There are some sort of logistical things you have to get through as a practice before you can offer it to your patients.
What are some of those?
The big one is the infrastructure involved. You have to have a good relationship with your hospital, your pharmacy, the infrastructure to handle the medication, because it needs deep cold storage to stay until its expiration date. And then once you sort of set the time clock for taking it out of the freezer, you sort of have a limited time to use it. And it's a new therapy, so it's not an inexpensive drug that you want to waste and not be able to use for your patients.
How's it administered?
It's administered, like many of our therapies, into the bladder.
Okay.
So it takes away that hesitancy of patients who have not wanting to get systemic therapy in the veins, and they've already had other intravesical therapies, and this is just a new drug to deliver in the same way.
So 50% recurrence rate, recurrence reduction is pretty impressive.
It's impressive. I mean, we're seeing also some other impressive results of some other drugs out there in this space, but certainly BCG failures out there about 40%. So the short-term data is very favorable.
And in terms of clinical trials coming up? What do we have out there?
So we have a lot. I think the future in this space is now we have, not just natafaragene, but we have Anktiva that also received FDA approval last year. I think now as we move forward, we're getting into more personalized medicine biomarkers. Are there biomarkers we can collect in patients to see which therapy? Sequencing of therapies, I think, is another active topic of research. What's better to give first? BCG first. If we fail BCG, instead of giving a second BCG, should we move to natafaragene? And then additionally, combination therapies with systemic immunotherapies are also many active open trials with some of these agents as well in this space.
So if I had to throw out a crazy question, do you think in 10 years from now, would cystectomy be an option, a treatment option for non-muscle invasive bladder cancer?
I mean, I still think, I don't know that I ever see a place where cystectomy will not have a role for some patients, because, when I counsel patients for this situation, even though it's a morbid operation and it's life-altering, it has very high success rates.
Right.
If you take out someone's bladder that has non-muscle invasive bladder cancer, 90% 5-year survival rate. The likelihood of recurrence is very low, comparatively speaking. So there are still patients out there who are going to be very young and sort of very aggressive with their treatment course. And I don't think it'll go away completely, but like everything in cancer care, we've started big, massive operations. We've switched to minimally invasive operations. And now we're doing a lot more bladder-sparing operations, which I think is the natural progression it is very helpful. And as I mentioned earlier, that personalized medicine, which approach, not just a blanket sort of statement for everyone, but sort of a individualized approach based on stage of disease, potential for biomarkers, et cetera.
Awesome. And so in your practice, for a standard patient with high-risk non-muscle invasive bladder cancer, you start with BCG?
Yeah, I mean, I think very guidelines driven. So
Okay.
I tend to follow guidelines for most things. So I give them BCG first line if we have it. As I mentioned earlier, the BCG shortage kind of put a lot of this into the limelight. BCG shortages have been better. It's now, thankfully, over the last 12 months, I've seen less of an issue getting BCG. Mm-hmm. But typically BCG first, typically reinduction BCG, and then, if they fail after that, then we're starting to potentially get into these other trials that we're offering, or certainly the FDA-approved therapies out there.
Is Gemdosi as part of your...
Gemdosi is a big part. I do, a lot of ongoing studies in that space. There's the Bridge trial looking at BCG-naive patients right now, but certainly the retrospective data for Gemdosi, there's a lot of positives. Okay. It's very cheap. For the most part, I feel patients actually tolerate that regimen a little bit better than even BCG. The challenge, of course, with that is the dual agent, so the time in the clinic, the dwell time, et cetera. But typically, my go-to if I have a BCG shortage is typically first-line Gemdosi. Or if they fail after BCG, then I do offer Gemdosi as another very easily available, cheap, and easy option for patients.
The bottom line is it's really, as a disease, we've really, created a new armamentarium. It's pretty impressive.
Oh, I mean, we're seeing now different viral vectors out there, strep pyogenes bacteria, and all these other things that are pretty incredible. So it's exciting to see what comes down the pipeline.
So awesome. Thank you so much for joining us.